sometimes see vesicle formation. I will show you pictures, but it is seen only in 1/5 of cases. What exactly happens in this disease is very, very simple. It is always associated with extra epithelial inflammatory reaction. Normally, if you have inflammation, it has to heal normal. Inflammation promotes healing. But in this particular disease, what happens? Because of that, there is stiffness of the oral mucosa causing trismus and inability to eat. When there is atrophy, patient cannot tolerate spicy food or hot food, there is burning sensation. So all the clinical features are quite self-explanatory when you understand the definition. Please remember, chronic disease affecting oral mucosa and pharynx can be preceded by vesicle formation. Main thing is inflammation followed by fibrosis. Because of inflammation and fibrosis, the mouth opening gets reduced, mouth becomes stiff, firm, blood vessels are pressed, decreased blood supply, epithelial atrophy, stiffness, trismus. That is what is oral submucous fibrosis. What causes oral submucous fibrosis? Yes, there is a strong association of betel quid chewing with the causation of oral submucous fibrosis. Now what you need to understand is, many of the patients come and ask us, everybody is chewing gutka, why everybody is not getting oral submucous fibrosis? For that, what we need to understand is the multifactorial model for pathogenesis of oral submucous fibrosis. Of course, the presence of local factors like aragonite is definitely important. Without that, you will not get to see oral submucous fibrosis. First thing that we need to understand is there is a genetic susceptibility. Therefore, people who are genetically predisposed to get this disease, only those people will get into oral submucous fibrosis. Number two, what happens is, when the betel quid habit is present, there is a constant irritation caused by this particular betel quid, which basically causes chronic inflammation. And what they have seen is there is activation of T cell and macrophages at this particular site. There are increased expression of these cytokines. As a result of this, main thing that happens is increase in collagen production. Please understand the collagen produced in this disease is abnormal collagen. Apart from that, there is a decrease in collagen degradation. So increased collagen, because there is a cross-linking of insoluble collagen, abnormal collagen, and decrease in collagen degradation causes fibrosis, resulting into oral submucous fibrosis. Now, how does aragonite or the gutka or the pan, which has got an important ingredient as betel nut, how does that contribute to oral submucous fibrosis? Let us just know. Aragonite contains three important ingredients: alkaloids, flavonoids, and copper. Please remember, alkaloids are the ones that stimulate the fibroblasts, because of which there is an increased production of collagen and persistent oral submucous fibrosis. Because of that, there is a juxtaepithelial hyalinization and there is a vasoobliteration, decrease in blood supply. Because of flavonoids, it causes cross-linking of collagen. It becomes resistant to collagenase, resulting in oral submucous fibrosis. Now, the copper present in the aragonite, what it causes the expression of the lysyl oxidase enzyme activity increases because of the presence of copper, because lysyl oxidase is dependent on copper, which stimulates fibrosis. And because of continued chewing and overactivity, there is muscle contracture, what you see in OSMF. And you all know, when you are continuously using the muscle, there is glycogen depletion from the muscle. Because of that, there is muscle fatigue and degeneration, finally leading to fibrosis and scarring of the muscle. This is how the contents of aragonite cause oral submucous fibrosis. Now, genetically, if you take or if you talk about this disease, it is essentially a collagen metabolic disorder, because if you look at the histopathological characteristics of OSMF, what you see is deposition of collagen in the oral mucosa or the oral submucosa. Now, it is very important to note that a biopsy is not necessary to diagnose oral submucous fibrosis. It is a clinical diagnosis, and whenever patient comes to you, if you have areas of suspicion, definitely it needs to be biopsied. In India, you are seeing males are more affected, and the age group affected is 8 to 80 years. About 24 years back, when I was doing my post-graduation in North Karnataka, I used to see oral submucous fibrosis in 7-year, 8-year-old kids. They also have the habit of chewing gutka, and the prevalence of OSMF in India is very, very high, ranging from 0.15% to 14.6%. What are the clinical features of oral submucous fibrosis? You get to see burning, vesicle formation, increased salivation or decreased salivation, abnormal sensations in the mucosa. Patient will tell you metallic taste is there, taste dysfunction is there, he is not able taste sensations. Patient will tell there is some kind of a dysastic feeling on the tongue. Patient can tell there is abnormal sensation, paresthesia of the palate. All these things can happen in early stage of OSML. Remember, in early stage, there is no decreased mouth opening, no fibrosis. Very, very important to recognize oral submucous fibrosis at this stage. You can see pigmentation and you can see ulceration. These are the patients that I'm showing. I'm showing an extremely enlarged picture. You can see a vesicle formation here in the left buccal mucosa in the retrocommissure. You can see hyperpigmented areas. You can see erythematous area here. You can see ulcerations here. You can see a ulceration here. So you can see a lot of bond stains. One peculiar thing that you'll have to understand in oral submucous fibrosis is in the initial stages when you get to see ulceration, what you get to see is the encrustations of the tobacco, the encrustations of the gutka or pan that are present in this particular ulcer. It has got that peculiar brownish tinge. I'll show you some more pictures later. So this is initial stages. You don't get to see fibrosis. In the moderate stages, you will start seeing blanching of the oral mucosa, especially the soft palate, buccal mucosa, partial pillars. The oral mucosa becomes rigid on palpation. You can palpate the bands, the palatal bands, buccal bands. There is difficulty in whistling. If you ask the patient to blow air or whistle, he is not able to do that. There is a puckered cheek appearance and you will start noticing the taste change. You can see decreased mouth opening. You can see deep appellation of tongue here. You can see there is a fibrosis of tonsillar pillars. And you can see because of the fibrosis, even the musculus uvula has taken the shape of a hockey stick. The uvula becomes a butt shape or hockey stick shape. And another thing is when any person opens the mouth opening shape is oval. In oral submucous fibrosis, because of fibrosis, you will see that the mouth becomes circular. This particular sign is called as circumrima oris. So this is blanching of oral mucosa. Because of vasoobliteration, you are seeing that it becomes extremely pale. That is known as blanching of oral mucosa. You can see blanching here, blanching in the labial mucosa, blanching in the floor of the mouth, blanching in the buccal mucosa, blanching in the lower lip, inner side of lower lip. You can see shrunken or bud-like uvula because of fibrosis. This is a hockey stick uvula, classically seen in oral submucous fibrosis. In severe stage, you will see complete depapillated tongue, decreased mouth opening, and severe blanching. So in severe stage, you will see that the patients are not able to eat food, and because of the fibrosis of the eustachian tube, patient will develop nasal twang and hoarseness of voice and deafness, and there is a hypertrophic masseter, loss of nasolabial fold and thinning of lips. Because of this hypertrophic masseter, if you take a orthopentamogram, the full mouth X-ray, you can also see there is a increasing the gonial angle because bone always yields to muscle. That is one way of identifying hypertrophic masseter. So one important thing that you need to recognize here is buccal mucosa is the most commonly involved. 98% of the times in oral submucous fibrosis, buccal mucosa will be involved. It is the first to involve. In advanced cases, the mucosa becomes tough and leathery with numerous vertical fibrous bands. Now bands in the initial stages starts from the palate, vertical bands, then you will see that there will be palpable fibrous bands on the buccal mucosa and finally in the labial mucosa. So you will get to see palatal, buccal and labial bands. Tongue involvement is also seen. Most of the times it will be blanched and there is a deep appellation. It is seen in 37% of cases. And the most famous clinical and functional staging as far as ease of treatment is concerned, there is a staging given by Haider et al. In 2000. It is stage 1, stage 2 and stage 3. When you are palpating, if only palatal bands are present, it is stage 1. If palatal and buccal fibrous bands are present, stage 2. It is stage 3 if it is palatal, buccal and labial bands are present. If you don't want to follow the palatal, the bands, for ease of thing, you can do the mouth opening, measure the mouth opening. If it is greater than 20 millimeters, it is A. Stage 2 is 11 to 19 millimeters of mouth opening. Stage 3 is less than 10 millimeters of mouth opening. Very, very important. Stage A can be managed pharmacologically. Stage B and stage C, by and large, requires a surgical management for opening the mouth. We will come to that later. So it is important when we are seeing oral submucous fibrosis, just to know what is the stage of the patient, are there any comorbidities present, and the management is medical or surgical. So before we go ahead with the treatment, most of these patients are not eating well because there is no mouth opening. So majority of them will have iron and B12 deficiencies. So please do a basic blood workup. and put them on replacement therapy. And biopsy is not preferred, as I told you, unless there is some suspicious looking lesions. Now I am showing you one lesion here. You can see a bud or a shrunken uvula here, fibrosis of tonsillar pillars. What you can see here is a beautiful red lesion intermingling with lot of keratotic nodules, this particular papillary looking lesions. This is not a good thing. Most of the times when you see this kind of appearance in oral submucous fibrosis, it will be dysplastic. What you need to do is you need to biopsy these kind of lesions. You can also see the same thing happening here. A granular appearing red lesion. Suddenly you see well demarcated. You can see fibrosis all around here, but here you are seeing this needs a biopsy. Both these cases were squamous cell carcinoma, and both the cases were cases seen in our hospital. And one of them was operated by Dr. Somshekhar also. So how do we manage oral submucous fibrosis? Habit cessation, which is very, very important. Unless and until you do habit cessation, one thing that you have to remember is even if you treat OLSMF, it worsens. Pharmacotherapy, physiotherapy, wisdom tooth removal, limited evidence. See, there is no evidence, as I told you, because we have not much data and studies without bias done everywhere. Now, the reason why I am talking wisdom tooth removal is the moment you get to see any oral submucous fibrosis, please set them for wisdom tooth removal. Because once the fibrosis increases and mouth opening comes down, it is very difficult for us to remove the wisdom tooth removal. So what I suggest is all oral submucous fibrosis patients, wisdom tooth should be removed. Now physiotherapy, you people are used to give that gauge, metal gauge which you use for mouth opening. What the data is anecdotal. I have found out that ice cream stick exercises are giving better results than that metal gauge, and people can use it more simple. The manner of using it, the manner in which they can use it for mouth opening exercise is more simple with ice cream stick exercise. We will come to that in the next slide. And what do you use for treatment? If there are no fibrous bands, topical steroids are enough once you do the habit cessation. If there are bands, lot of literature is there. People give injections, intralesional injections of hyaluronidase, laxatrix, dexamethasone, triamcinolone, a combination of these things, permutation combination of these things. But of late, what literature is telling that the trauma caused by intralesional injection is also inducing fibrosis. So as long as the patients are taking injections, you are seeing that the disease improves. But once you stop injection, over a period of 6 months, there is a reactional fibrosis. Again, the mouth opening is coming down to same. So what I do in my practice is definitely level 1. I told you that there is a level 1 evidence that after giving injections, there is a relapse in the fibrosis. So what I do in my practice, I use clobetasol propionate cream, and I make sure that the cream stays on the lesion, on the mucosa, for at least half an hour time. And you can also use the saltless butter and betamethasone preparation. And you will have to teach the patient how to apply this cream, because most of the patients do not know where to apply because of decreased mouth opening. Ask the patient to bring the medicine, seat them in front of you and teach them how to apply. That is more important, because the most important thing in treatment of oral submucous fibrosis or any oral mucosal lesion for that matter is residence time of the medication. How much time the medication stays in the mouth is the most important time, because it is very, very challenging. Saliva literally wipes out everything that we apply in the mouth. So as I told you, the ulcerations in the oral submucous fibrosis will have that particular gutka tinge. You can see the difference in the color. So after putting the patient on a topical steroid, you can see after 1.5 months, you can see that the ulcer is healing on this left retromolar trigon. You can see ulceration covered with slough and containing the encrustations of the products of gutka. You can also see keratosis. Now here the healing process has started. Keratosis has also started to disappear, and you can see it is almost healed in this particular thing. Please remember, unless the patient stops the habit, these things are not going to happen in spite of giving medications. Now coming to pharmacotherapy, normally I follow multi-drug regimen. As I told you, start the patient on antifungal. Gluconazole 150 milligrams once a day for 5 days. Tons and tons of literature is available on fungal colonization in oral submucous fibrosis. Any potentially malignant disorder, that's why I say start the patient on an antifungal and then switch on to your pharmacotherapy. Normally we give a preparation that contains multiple drugs like lycopene, beta-carotene, selenium, zinc sulfate, And we also give curcumin, which is an extract of turmeric, 500 mg PID for 3 months. Again, I am pointing out habit cessation is the most important thing that we need to follow. Along with that, if you treat the patient with this for a period of 3 months, definitely it will be important, it will be helpful. Then balloon inflammation and ice cream stick exercise. There is a particular manner how you have to ask the patient to do this. Let us assume that on day 1, when you see the patient, about 10 sticks are going inside the mouth. What you have to ask the patient to do is keep the sticks for about 20 seconds and remove the sticks for 20 seconds. That is one cycle. Like that, you ask the patient to do it for 20 cycles in the morning and 20 cycles in the night. And most important, ask the patient to increase it by 1 stick once in a week. That is how slowly you will get to see mouth opening. There are other modalities for treating. You can use lasers to sever the bands, but therapeutic lasers are not helpful. And other pharmacological modalities, when patients are not responding for those 2 drugs, we switch on to pentoxifylline, which is basically a peripheral vasodilator, has a good result in treating oral submucous fibrosis. 400 mg thrice daily for 3 months, we give it, and we are seeing good results. Now coming to surgical therapy, you are the masters of this. I did not teach this to you. You will see submucosal resection can be done, replacement with partial thickness skin or mucosal grafts. But the literature says, and anecdotal data from most of the oncosurgeons, including Dr. Somshekar, what we have seen is whatever is the type of flap you put in oral submucous fibrosis, that also gets fibrosed. So the best flap that you can put, which cannot be fibrosed, is a radial forearm flap, which is a vascular flap. And I think Dr. Somshekar has operated some cases in the past where he has used jejunal mucosa. He has taken jejunal mucosa and implanted it on the surgical site in the buccal mucosa after severing the fibers, and it goes to say that this jejunal mucosal flap has got 0 fibrosis post-operatively. And in patients whose mouth opening is very, very less, you can do this bilateral temporal myotomy. And if you do these kind of procedures, surgical procedures, please remember oral stents are required for the patients post-operatively, because if you just leave it like that, again there will be fibrosis. These are the potentially malignant oral diseases that I wanted to discuss today. Thank you very much for your patient listening. See, it is very difficult to cover all the lesions in a span of 1 hour. I have tried my level best to give you information that can help you in treating patients and also writing your exams. Once again, thank you for your patient listening, and thank you, Somshekar sir. Okay, I think the first question was, you want me to show the list of lesions showing the differential diagnosis of leukoplegia again? Sir, you want me to do that now?
You may just pick up the relevant questions, and because we have 5 minutes, 5 more minutes.
See, traumatic keratosis is not, Dr. Abhishek Verma has asked, is traumatic keratosis precancerous? See, traumatic keratosis is not precancerous. What you have to understand here is, if there is a traumatic lesion, let us say a sharp tooth is impinging on the mucosa and causing an ulcerative lesion, and the patient does not attend to it, so directly patient is getting a carcinogenic exposure to the connective tissue through the ulcer. That kind of a lesion is precancerous. See, we say sharp tooth causes cancer. Tooth does not cause cancer. erythroleukoplakia. Even in these instances, if you view the lesion under a magnifying lens, you will still get to see small papules in a lichen planus lesion. Or if you still feel it is difficult, biopsy is the answer. First few slides before leukoplakia again, please. I will do that at the end. All sharp tooth and wisdom tooth should be removed prophylactics or person with no habits. You should not remove wisdom teeth for anyone with no habits. I am giving that distinction only for oral submucous fibrosis patients because in this generation, wisdom tooth is like a vestigial organ. Majority of the individuals will not have space to accommodate wisdom teeth. So they will be in a wrong direction or they will be directed towards the cheek or the retromolar tricone. Once the patient gets into oral submucous fibrosis, in future he might go into moderate or severe stage. Then it becomes extremely difficult for us to use our forceps and remove the teeth. Only for those individuals I am reserving the act of doing prophylactical removal of wisdom teeth. Otherwise, patient should not remove any wisdom tooth. Now coming to sharp teeth, if the sharp teeth is decayed, do appropriate treatment. If it is not decayed, you can just smoothen the sharp teeth and then leave it. No need to extract.
Yeah, thank you, sir. So we have.
Used for treating lichen planus lesions, especially recalcitrant lesions of lichen planus, but we are not